Hi friends, welcome to Plexus Ortho. My name is Dr. Kannan Kumar and today we are going to discuss how to read an bone lesion X-ray. We already discussed in part 1 about how to exactly go about looking at an X-ray with a bone lesion. Because your NEET PG exam is beginning to have more and more questions on image-based questions, so we have to have an understanding about how to read these bone lesion X-rays. So since your NEET PG exam has at least one radiograph on a bone lesion, we must be very careful and we must look at how to read a bone lesion and make sure we can get a diagnosis out of it. So therefore, we are going to look at a series of X-rays about how to come to a diagnosis regarding the lesion and what answer to pick, and in case they have a two-step answer and what therefore what diagnosis and what treatment you have to give. So these are the things that we are going to look at in the following slides. So let us say you are presented with a lesion like this. So the first thing that you should look in any X-ray is which bone is involved. So in this case you can see the femur is involved. Number one, which part of the bone is involved? It is probably the metaphysis which is involved. So which bone is involved? The femur is involved. The second thing you should look is which part of the bone is involved. Is probably the metaphysis in this case. The third one you should see is the zone of transition. So in this case we can clearly see a geographic lesion with a sclerotic margin, and we know very well that a lesion, benign lesion, has usually a sclerotic margin, and when it goes more and more aggressive and becomes malignant is when you start to have permeative moth-eaten appearance, where the boundary between the normal bone and abnormal bone is not very clear. So the third thing that you see is zone of transition. The zone of transition is very clear cut in this case. There is a sclerotic margin and therefore it is more likely to be a benign lesion. The fourth thing that you see is a periosteal reaction. In this case we see no periosteal reaction. There is no effort of the bone to grow or stimulate the periosteum, or there is no effort of the tumor to break out of the cortical bone. So there is no periosteal reaction in this case, and this indicates more towards a benign lesion. Then we look at the matrix. What kind of matrix is that? This appears to be a ground glass appearance. There is no osteogenic or bone formation potential, or there is no chondrogenic or chondrocytic influence in the center of the bone, and therefore you have to look at the matrix as well. So this matrix is probably ground glass in appearance. The sixth thing, they look at the size of the lesion. The size, it looks to be somewhere between 4 to 5 centimeters by about 1 centimeter in size, and therefore it's not too large as well. So seventh thing that you see is what is it doing to the cortex. This is probably causing a little bit of the scalloping of the cortex. So we call this as an endosteal scalloping. Endosteal scalloping. So what can we deduce from all this? It looks like a benign tumor with a sclerotic margin. It is in the metaphyseal region in the femur. Most likely this is either a fibrous dysplasia or a non-ossifying fibroma, right? So it is a benign lesion. So you can pick one of these answers in your question. So fibrous dysplasia, ground glass appearance, metaphyseal diaphyseal region in the femur. Zone of transition is very clear cut between abnormal bone and normal bone. This kind of indicates a benign tumor. Benign tumor, most likely a fibrous dysplasia or a non-ossifying fibroma, right? So this is very clear. This is the 7 stages or the 7 steps in which you look at a X-ray, so that you never miss an X-ray of bone lesion in your NEET PG exams. So let us look at the second X-ray. Whenever there is a distal end radius lytic lesion, the first thing that you should go for is a giant cell tumor of radius, and then rule out the other things. Okay. So the giant cell tumor of the radius is a favorite question of your NEET PG examiners. It's very commonly asked. So therefore you first go there and then you can rule out all the other conditions. Anyway, let us be a little bit more methodical and find out the answer in this X-ray. So the first thing that you should look at is the location of the bone. Which bone is involved? The distal radius is involved, right? The second one is what part of the distal radius is involved. You can see the metaphyseal, epiphyseal area of the distal radius is involved, right? Then third one is what is the type of lesion and what is the zone of transition, right? It's an expansile lytic lesion. It is a geographic lesion definitely, because it is clear, the margins are clear cut, but there is no sclerotic margin. So the previous X-ray we saw that there was a thick sclerotic margin. Here there is less or no sclerotic margin, Therefore, it's a little more aggressive than the previous tumor, but it is still not gone to the other spectrum, that is moth-eaten, or the zone of transition is still very clear. Therefore, there is a clear transition between the abnormal bone and the normal bone. The fourth thing that you look for is a matrix. Here also we don't see any chondrogenic. There is no chondrogenic or osteogenic potential. Okay, so you can rule out the chondrogenic and osteogenic tumors by looking at the matrix. Osteum is not elevated, or there is no periosteal layering, so there is no periosteal reaction. The sixth one is the size is considerable. It involves most of the distal radius, and to the cortical bone it has disrupted a part of the cortical bone here and here. So there is some aggressiveness in the tumor, there is some involvement of the cortical tumor. So looking at the distal radius, the physis has closed. It's an expansile lytic lesion. There is no chondrogenic or osteogenic potential in the bone. There is no periosteal reaction. The most likely diagnosis in an adult with the growth plate closed is a giant cell tumor. Giant cell tumor. What is the treatment for giant cell tumor? The treatment for giant cell tumor is extended curettage and bone grafting, right? So the tumor is extended curettage and bone grafting. Sometimes we use a rank ligand inhibitor called as denosumab, which acts on this tumor and causes debulking of the tumor before we can go for surgery. So denosumab is also used. So based on our systematic approach to this X-ray, we can most likely deduce that it is likely to be giant cell tumor. It is a little difficult to differentiate between giant cell tumor and aneurysmal bone cyst. You must remember that aneurysmal bone cyst occurs before the physis closes, whereas the giant cell tumor occurs after the physis closes. Giant cell tumor occurs from the epiphysis towards the metaphysis, whereas the aneurysmal bone cyst occurs from the metaphysis towards the epiphysis. These are some of the differences between giant cell tumor and aneurysmal bone cyst. They're very difficult to differentiate. Okay, let's look at this another benign tumor. Okay, so the first thing is the location is in the humerus. The location is in the humerus. The second thing is it is in the location in the bone is it is metadiaphyseal, right? The third thing is zone of transition is clear. Of course, there is no zone of transition is clear. There is no sclerotic rim, but it is a geographic expansile lytic lesion, slightly expansile, but there is a clear demarcation between normal and abnormal bone. The fourth thing is matrix. There is no chondrogenic or osteogenic potential, right? But pathognomonically in the matrix you can see what is called as fallen leaf sign. So this should direct you towards the diagnosis, fallen leaf sign. The fifth thing that you can see is for you look for is a periosteal reaction. There is no evidence of any periosteal reaction. No periosteal reaction. The size of the tumor is considerable. It includes most of the width of the bone. There is a little bit of thinning of the cortex. You can see that there is a thinning of the cortex that we will see in the as a seventh parameter. So the thinning of cortex. There is also a breach in the cortex here and here. This indicates there is a pathological fracture. Because a fracture occurs, a small piece of the cortex falls into the cyst, and this is called as a simple bone cyst or unicameral bone cyst. So don't be confused between the simple bone cyst and the unicameral bone cyst. So looking at our this thing, we have deduced that it is there in the humerus. It is in the metadiaphyseal region. There is clear zone of transition, or there is a good demarcation. It is a geographic lesion without a sclerotic rim. The matrix does not contain osteogenic or chondrogenic problems, and there is no periosteal reaction, right? And the size is considerable, involving the whole of this thing with thinning of the cortex and break of the cortex. The most common condition presenting like this is a simple bone cyst or the unicameral bone cyst. Both are the same, right? Don't get confused between these two terms. They may be given interchangeably in your exam. Simple bone cyst and unicameral bone cyst are the same, and the pathognomonic feature that you see in this condition is called the fallen leaf sign, or where the fragment of bone or a piece of bone falls into the cavity, and this is called the fallen leaf sign, right? What is the treatment for simple bone cyst? Simple bone cyst, simple aspiration and steroid injection can be given. Conservative management can be done. Curettage and bone grafting can be rarely done in these cases. How do you differentiate between simple bone cyst and aneurysmal bone cyst? Aneurysmal bone cyst is in the metaphyseal region abutting the physis, whereas Simple bone cyst is more metaphyseal, diaphyseal, and simple bone cyst is more central in location. Aneurysmal bone cyst is eccentric expansile. So if you see an eccentric expansile lesion abutting the physis, it's more likely to be aneurysmal bone cyst. Whereas if you see a central expansile lesion in the metadiaphyseal region, it is more likely to be a simple bone cyst. The fallen leaf sign is pathognomonic for a simple bone cyst. Remember this. So here we see an X-ray of a immature child. The growth plate is still open. So the first thing that you see is the lesion in the distal radius. If you see a lytic lesion in the distal radius with the growth plate closed, it is a giant cell tumor. If it is an expansile lytic lesion with the growth plate open, it's most likely an aneurysmal bone cyst. So let us look at all the other characteristics that we are looking for. The second thing, it is in the metaphyseal region. It is in the metaphyseal region. Giant cell tumor occurs from the epiphysis towards the metaphysis in a adult patient, whereas aneurysmal bone cyst occurs from the metaphysis towards the epiphysis in a immature or a child. Right. The third thing that we see is zone of transition. Zone of transition is fairly clear and well demarcated. There may be a sign of a sclerotic rim, but it is very faint. So zone of transition is very clear. Right. And the fourth thing that you see in the matrix, there may be some kind of osteogenic potential here, but overall it is mostly clear. There is no chondrogenesis or much of osteogenic potential in this area. Then you see periosteal reaction. There is minimal or no periosteal reaction. So in benign tumors, it is a recurring pattern that you will not see any periosteal reactions. Once you see a periosteal reaction, it's either an infection or a malignant bone tumor. Remember that. The size of the tumor is considerable. It's eccentric and expansile lesion. Eccentric expansile lesion engulfing most of the distal radius and thinning out the cortex considerably. So it is thinning out the cortex considerably. So therefore, these are the parameters in which we look at the tumor, and looks like most likely it is an aneurysmal bone cyst. What are the features in favor of aneurysmal bone cyst? The growth plate has not fused, number one. It is an eccentric expansile lesion. There is no periosteal reaction. It is in the metaphyseal region abutting the physis. If it was the other way around, it would be a giant cell tumor, right? So the diagnosis for this is in all likelihood is going to be aneurysmal bone cyst. So let us look at this CT slice. So unlike an X-ray, this is a CT slice because I thought this is more representative of this condition. Right? So the first thing that you can see is that there is a lesion in the distal femur. Okay. The second thing is it is in the probably in the diaphyseal region, which you can't make out here, but it is in the diaphyseal region. Let us assume that it is in the diaphyseal region. The third thing is the zone of transition is very clear with sclerotic, very thick sclerotic margin. So zone of transition is well demarcated. That means this indicates a benign tumor. The fourth thing is the matrix. You can see calcification in the center of the bone, and this is called as osteogenic calcification, osteogenic matrix. There is some amount of periosteal reaction can be seen in this surrounding area. So this is one condition where periosteal reaction does not indicate a malignant tumor. Size, it is probably less than 2 centimeters. This is very significant. We have to keep this in mind. 7. It is in the cortical area. It does not involve the medulla here. It is in the cortical area. So what is the diagnosis here? It is osteoid osteoma. Osteoid osteoma. It is the most common true benign tumor of the human body. It's the most common true benign tumor. Osteochondroma is the most common lesion, but the most common true benign tumor is an osteoid osteoma. Patients complain of night pain, and they have this, it is relieved by taking salicylates, and the treatment of choice for this is radiofrequency ablation of the osteoid osteoma. Now, what is the problem with its size? If it is less than 2 centimeters, it is an osteoid osteoma. If it is more than 2 centimeters, it is an osteoblastoma. Right? What are the most common locations in which osteoid osteoma occurs? It occurs in the long bones of the body, and it also occurs in the posterior elements of the spine and can cause a painful scoliosis. So osteoid osteoma and osteoblastoma. Osteoid osteoma is less than 2 centimeters. Okay, let's look at another benign lesion. This is a patient who's reached maturity. You can see the growth plate is slightly closed. There are multiple lesions all around the knee joint, right? So this is a straightforward spotter question. This is a case of multiple hereditary exostoses, right? But let us be a little more systematic and look at it. The first one, it is the distal femur and the upper tibia, that is, it is around the knee joint that the X-rays is put up. The second thing, it is in the metaphyseal region, very clearly in the metaphyseal region. You can see multiple regions in the metaphyseal lesions. The zone of transition is very clear. You can see there is some sclerotic margin all around. So it is not, it is very well demarcated, indicating it is a benign tumor. The matrix is, there is some chondrogenic, that is, there is some trabeculae. You can see the trabeculae and bone formation here. So there is some osteogenic or bone formation here. 5, there is no periosteal reaction. No periosteal reaction. Size, it is of various sizes all around, right? And cortical involvement, of course the cortex has opened up, so it's in some cases it is like a stalk, like in this one, whereas in some cases they're pedunculated, they have a broad base. So they have a stalk in some cases, and some cases they're sessile or they have a broad base. So these are so the diagnosis is multiple hereditary exostoses, multiple hereditary osteochondromas, right? So this is an autosomal dominant disease, and it's due to a defect in the enzyme called as EXT gene 1 and EXT gene 2, right? So this is the diagnosis. You can come to a logical conclusion with the help of various parameters. Looking at it, you can make a diagnosis. Even if you don't know the lesion in the exam, using these parameters, you can come to a conclusion whether it is benign or malignant. Basically, once you get to know it is benign, then you rule out all the other options, and then you can probably 99% of the time select an answer without even knowing what the lesion is, by understanding how the tumor behaves on the X-ray.